Hello, everyone. Thank you for coming. So my name's Emily. I am the public safety reporter with the Gazette, and I am also the track lead um, for Iowa Ideas for the Human and Social Services track. And so I'm here going to be moderating this session. Welcome. This is the Supporting Iowans in Crisis session of our in-depth week this week on mental health in Iowa. And so we'll be talking about mental health specifically in the context of police and law enforcement and kind of where the line happens between law enforcement and our mental health liaisons across the state. So before we get started, we want to shout out our presenting sponsor for this in-depth week. I've got this little blurb I'm supposed to read here. It says, Iowa Ideas is a year-round series of content and gatherings, including this week's in-depth week. Thanks to presenting sponsor ITC Midwest for their sponsorship on all things related to Iowa Ideas in 2024. And thanks to this in-depth week's presenting sponsor, Foundation 2. So yeah, I hope everyone is in the right place. We've got some wonderful panelists here to talk to us about mental health crises and how we react to them. So I'm going to start off by just having each of our panelists introduce themselves and tell us about kind of their connection to the topic and why they're here, and then we will jump into some questions. Audience members, feel free to send in your questions and we will try to get to as many of those as we can. And then if no one has anything, I also have a whole list that I can pull from. So let's start off with Tony. Do you mind introducing yourself for us?
Hi there, I'm Sheriff Tony Thompson, and I am the Sheriff of Blackhawk County. I've been with the county for 31 years, originally as a sheriff's deputy, and now the last 16 years as sheriff. And I just recently, as a knuckle-dragging cop, wrote a book called Any Place But Here, The Uncomfortable Convergence Between Mental Illness and the Criminal Justice System.
Awesome, thank you. Gabe, you're next on my screen.
I'm Gabe Martinez. I am the Assistant Vice President of Community Mental Health at Broadlawns Medical Center in Polk County. I've been providing mental health services for over 20 years. And I get to run and be in charge of our mobile crisis unit that responds to crisis calls in the Polk County area as well.
Awesome, thank you. And then Erin.
Hi, everyone. My name is Erin Langdon. I'm the Chief Operating Officer at Foundation 2 Crisis Services. At Foundation 2, we provide mobile crisis for 11 counties, as well as have embedded co-responders. We call them law enforcement liaisons in 8 different departments, from Cedar Rapids all the way up to Dubuque, kind of on the curve in eastern Iowa. So we respond to Iowans in crisis that way, as well as answering 988 primary for phone and Your Life Iowa as 2 of the main crisis lines here in Iowa.
Awesome, thank you guys. We're excited to hear all of your thoughts kind of on this important topic. So I'm going to throw out some questions. All of my questions are very general, so any of you are welcome to answer. If we get any questions that are for a specific panelist, I will let you know when I ask those from the audience. But to just start off kind of generally, what are the problems that we're seeing right now in Iowa when it comes to mental health crisis response?
I think no one wants to talk over one another. So
Go ahead, Erin.
Crisis services are vital in Iowa because it's that point in time intervention when someone's life, their circumstances have put them in a point in crisis. And a crisis is very individualized. We don't try to define a crisis for someone, but the ability to call a crisis line or to have an in-person response, whether that's via mobile crisis, or if someone is in dire need and they call 911 because it's a number that they know, that they get that mental health response. So I think where we need more crisis services providers so that we have those services in all 99 counties. We are a very rural state, so the urban centers, I'm sitting in Cedar Rapids, I'm guessing Gabe might be in Des Moines, and Sheriff Thompson in Waterloo, there are more people to do those responses. So I think that is one of the things that the state really needs to continue to focus on, and to recruit employees that that live in our rural communities that want to do this work. I wholeheartedly believe that it is the person that you bring to work and the trainings that crisis services providers give to our employees that provide that successful intervention. And I just want every Iowan to know that those that are doing crisis services work are saving lives all of the time. There's just not quite enough of us, and as many communities and counties that are needed.
One of the things I think is important too, when Erin talks about intervention, she's also implying diversion, right? Diversion. So if there's not an interventionist, if there's not a social worker, if there's not a crisis responder who's not a law enforcement officer responding to that person in crisis, the implication is that we're diverting them from the criminal justice system, right? That we're not misinterpreting those in crisis who are screaming, yelling, biting people on the ankles, talking to the gas pumps, whatever symptomology they're displaying that is creating this outburst that is, disruptive, that is not being misinterpreted as criminal, and that we are able to divert in that intervention so as to not unduly criminalize the person in crisis, right? And I think that takes on a different perspective or a different complexion depending on where you're at too, because divert to what? In the larger centers where Des Moines and Cedar Rapids, Blackhawk County, Waterloo, we have some options available to us, where in more rural settings, there's still a lot of desert out there. There's still a lot of lack of resources out there. So that's another answer to the question. We still need options. We still need options to divert to.
I think when it comes to this question, Emily, I think our data, people who do collect data, our data does suggest that unfortunately people are having mental health crises or even substance abuse crises at an increased rate than maybe previous years. So I know here in the Polk County area, we have seen an increase in the amount of services that we have been providing to individuals that are in need of mental health services. So that is a big problem in the state, that the numbers are telling us that the need is increasing substantially.
Yeah, definitely. I know in the past few years, there's been a lot more emphasis on bringing in those mental health liaisons to work on that diversion, as Sheriff Thompson was talking about. But let's talk a little bit about that rural urban divide that you guys mentioned. How are things different for people in our larger cities versus people who may be having these crises in areas that just don't have those same resources?
Erin, maybe that's to talk about.
And speaking in regards to larger cities, I think with me being in Polk County, Broadlands being here in Polk County, and our mobile crisis primarily being in Polk County, there are available resources. But is there enough? It's hard to answer that question, because you almost feel like there's never enough services out there available. And I think when it comes to the big city, we have multiple hospitals, we have multiple providers providing similar services and stuff like that. So, but that does make a difference when it comes to the rural communities, because they have to come to us if they want services. So it does become a challenge. How do we go to them? Because that's ultimately what we're trying to do when it comes to crisis services, is try to go to the person where they're at, to try to hopefully minimize the effect of their mental health crisis, substance abuse crisis. That way they don't end up like Sheriff Thompson says, they don't end up in prison, jail, and/or in the hospital if it's not needed.
One thing that at Foundation 2 that we've tried to do is we look at our co-responders, so our mental health counselors, our crisis counselors that are embedded in departments. We have both urban departments and rural departments. So we have counselors who are embedded in the Buchanan County Sheriff's Office, as well as Delaware County and Benton County. we approach those responses slightly different than we would in the Cedar Rapids Police Department, where we also have 2 employees. So we have worked really hard with the deputies and some of the smaller school districts and community partners in those rural areas to explain what the response is going to look like, that you might see a deputy first because they could get to you sooner, but you will see a plainclothes Foundation 2 employee who's trained in crisis counseling as soon as they can get there. We also are really trying to utilize, for some of our bigger counties geographically, technology. It's become our friend and maybe our foe in the last few years, but it is our friend in crisis services, so that a law enforcement officer can introduce the crisis counselor to someone in a rural area. As like Gabe mentioned, we're making our way to them because we know the best intervention is if we can get to the person that's in need, but we're a big state and we are a lot of counties. So that's one thing that we've approached in rural areas. And to Gabe's point, in Cedar Rapids, in Dubuque, in the Quad Cities where we respond, there are more hospitals, there are more crisis stabilization beds. We're going to work that continuum as best we can to keep someone in the lowest level of intervention that's appropriate for their needs. And every individual and every behavioral health crisis is unique. And we've also really worked diligently with our rural counties to come and talk about what crisis interventions are and how we can be a tool to a law enforcement officer or a sheriff's office. We really want to help them with their jobs. We want to free them up to do the hard work that they're doing when they're dispatched off 911. So if we're able to stay with someone and stabilize them in their home in a smaller community in Iowa, or potentially transport them to a city if they need a crisis stabilization bed or a higher level of care, that frees up our law enforcement officers to do their jobs as well. So it's hard work and it's continuing, but that's something that we've seen success with, and we want to continue to work with our rural communities in that way. And we need more services in our rural communities. We need more hospitals. We need more options. I'm not trying to state that as well, but
We know that we rank poorly when it comes to the number of beds available, the number of providers available, right? We're like 50th or 51st in the United States because of some of those factors. And so recognizing that we are representatively poor in the state because of those kinds of things, and we've got 99 counties. Every county sheriff would love to have that personal touch, right? Have Erin's staff out there with us responding to every mental health crisis we have. If the best that we can do is telehealth, telepsych, where we, put a monitor in front of somebody and have that interaction that way, it's better than nothing. It's not ideal. It doesn't give the full feel of the situation in the response at the moment, but it is better than nothing. And those are the kinds of situations that we continue to work through. Maybe by reducing from 13 mental health service regions to 7, we get a little better consistency across the board with narrowing the scope to 7. We'll sit and wait and see. We'll hold our breath and hope.
Yeah, definitely. Let's talk about that a little bit. I think they just signed that bill within the last couple of days, right? That they're adjusting kind of the statewide approach to mental health. What are some of the changes that you guys are anticipating to the work that you do because of that new rearrangement of the mental health sectors?
I'll speak to one thing that I think is important. We are part of the Linn County Mental Health Access Center. So essentially the behavioral health urgent care. Anyone can walk in and get some crisis counseling and triage for what services they might need. What's limiting right now in the current system is if substance use is part of that, our funding structure, because it's a separate system, can say that's not a mental health crisis, that's a substance use crisis. That is a limiting factor for Iowans. So as Sheriff Thompson indicated, we're not exactly sure what the realignment and the bill that Governor Reynolds just signed is going to do for our system, but it does put substance use and mental health together, and that is crucial. Someone who is struggling with a mental health crisis often has substance use involved, and for the system to be limited to then not provide the funding for that crisis intervention is damaging to Iowans. So I'm excited for that piece alone. I do believe that the intent of Health and Human Services is for parity and to try to build a system that's replicable in Iowa communities. Those intentions are great, and we would like to see what Des Moines and Cedar Rapids has been able to be accessible to as many Iowans as possible. And it's a big lift. Realignment is going to be a lot of hard work, but I know that from Foundation 2's perspective and all of the providers that we partner with, we're here for that because we want to be a support for Iowans in that time of need. But that is one thing I'm looking forward to. Those systems separate has not been working for Iowans.
Yeah, definitely.
I'm going to agree with Erin in some of her thoughts, but I'm going to switch it up and say that one thing that I am excited for is the fact that we're going to have regions owned that are going to be owned by an entity that's going to be able to provide the services to a greater swath of people. So that way, things that like Erin said, things that are being done in Des Moines and in Cedar Rapids can be replicated in those smaller communities, those smaller counties, to fit the needs of those counties as well. So that way they don't feel like they're being left behind. That is something that I am looking forward to in this mental health redesign, is that these regions are going to be able to pull a little bit together and make sure that that whole region is getting the same service, rather than one county saying, well, I'm going to pick from this menu, I'm going to pick 3 of these items, where Des Moines might be able to pick 7 or 8 items on their own and stuff like that. So that's something that I am looking forward to in this redesign bill as well.
I'm going to be the pessimist in the room because cops are the eternal pessimists, right? We already know that all the best ideas, no offense, Gabe, all the best ideas come from Des Moines, right? They don't come from the field. They don't come from the trenches. They come from that Golden Dome in Des Moines. And I'm a little bit nervous because for the longest time, our region was the largest region with, I think we had 22 counties. And through our own experience, we recognize that 22 counties spread from Emmitsburg all the way, or Esterville rather, all the way down to Waterloo was too large. It was untenable. And so we started self-attriting down to, I think we're to 13 counties now. When you reduce from 13 regions down to 7 districts, I'm a little bit nervous that we may be replicating the same experience that Blackhawk County and our region already experienced, where we're forcing more counties into a district, I think we're calling them, and we may find that that's untenable. It's too large to manage that many counties together. And so I'm a little bit nervous about that. The other thing that I'm a little bit nervous about, I recognize what Erin said, that by putting the 2 big bullies on the block, substance abuse and mental health together, we are able to break down some barriers and bridge some siloed services. But I also recognize these 2 big bullies deserve a whole lot of attention and a whole lot of funding together. I hope we're not putting them into a ring where they have to fight against each other for funding, because it tends to be kind of the Iowa mantra where every individual, circumstance has to fight for its own. I don't care if we're talking about tuberculosis and, treatment and detection, and, you got to kind of fight for your little niche of the pie. And by putting those 2 together in the same ring, we may end up having to fight against each other. And obviously both of those need their own individual attention, and they both deserve and need the funding necessary. So that's the pessimistic side of what I see, and it makes me nervous. We'll hold our breath and we'll see how it all shakes out.
Yeah, for sure. We got a question here from the audience, jumping back a little bit in the conversation, but directed at Erin. But I think this is something you all could maybe speak to, but specifically at Erin. They asked, how do you measure success for the liaisons that you're dispatching with local police departments?
That's a great question and something that we are refining every day. But as Sheriff Thompson mentioned, we measure diversion. So the way our liaisons document is if if the call that they go off on the radio, they carry their own radios within their own departments and are dispatched from the dispatchers that are also doing that life-saving work. If there was probable cause for an arrest and we were able to divert that individual to, let's say, a stabilization bed, we know we're saving the system money. What I'm still trying to finesse is those rates, and I've got rural liaisons versus urban. So I'm actually working really diligently to get that number. But anytime a mental health counselor in a department is able to keep somebody out of a hospital or a jail, we are saving the system money. And we're also not ensuring, but helping to make sure that that individual is on a better track for well-being. Because to Sheriff Thompson's example, if we're arresting somebody that's presenting in a way that as a trained law enforcement officer, or they might jump into a criminal act unknowingly because their mental health is not at a place where they even really know they're breaking the law, getting into that criminal justice system could be setting that person up for ongoing crises and individual costs increase with legal fees and maybe some time in jail. So we do, the way we document is if there was probable cause for an arrest, and we work with our law enforcement officers on that, and if we're able to divert from a higher level of care, and we're finessing that and working with some of our partners, an ambulance ride, if we're even able to avoid an ambulance ride and we transport somebody to an access center or even a hospital, if that's a necessary level, we're saving communities money. So that's what we do. We've grown pretty quickly. So we were 2 liaisons about 4 years ago. Now we're 9. So we're still working on that formula, but we do track that information. We share that with our funders, with the state, to show the efficacy of these roles. We know they're effective qualitatively. I can say the smile and the joy and the peace that these counselors bring, but we also know that quantitatively we are making a big difference to the larger system.
Yeah, definitely. I like that the funding side of things and the benefit you're providing to counties as far as the cost also tends to align pretty well with the benefit to the individuals and making sure that they're able to receive that more personalized care. Another thing I wanted to talk about, and this was briefly touched on before, but just looking at where Iowa ranks as far as the availability of these services. Sheriff Thompson, you mentioned that we're doing pretty poorly compared to a lot of other states. What is happening across the country in these other states that are doing really well that Iowa could attempt to emulate? Where are our opportunities for growth, I guess?
Well, I think one of the things that was enumerated in a talk that we just recently did that I think is absolutely on point is management, case management, where you can follow from point of intervention all the way through, making sure that on all these off ramps, whether it's counseling, pharmacology, that you've got somebody that is a constant that's going to stay with Erin all the way through to ensure consistency for Erin all the way through the system. And we really don't have a good handle on that. And that's, I think it is a key piece of lack of provider, right? The MCO system didn't help with a lot of that because a lot of people said, hey, if you're not going to give me fair reimbursement, I'm out. But I think that's a little higher upstream than just a simple care coordinator that's going to help us bridge all these siloed services that are out there trying to do good work. That really we just need to span and stretch across all those siloed services of all these great community outreach opportunities that exist, just to help coordinate for these folks that can't coordinate for themselves, or advocate for themselves, to make sure that all of this great resource that exists out there just is taken advantage of. And maybe that's a poorly way to express that, but truly, there's great resources all over the state of Iowa and great people out there wanting to give help. We just need somebody that can exercise the muscle that's going to allow for those things to occur.
I believe as a state, we should not be afraid to try new things. And I think that's where the state is starting to turn a little bit when we think about how we're providing the service that we're providing. You know, for example, a lot of our mobile crisis services, for example, here in Des Moines, we have the privilege of what we call our care team, and it's embedded in Des Moines. It's only a Des Moines service at this time in the city of Des Moines, but that is a response model where we go out without police involvement. You know, so we at this team can go and intervene for low-level threat situations to provide a service where it's definitely not police-based, but they can give the person the resources that they need at that time because they are calling for a crisis for whatever it may be. But that way we can take the police involvement out of that, let the police officer go deal with higher level crime situations so that we can separate those two worlds when that's possible. But as a state, we just need to be willing to say, all right, we need to find some money that gives us some flexibility to be able to try something new.
Yeah. I'm reminded a couple weeks ago, my little sister, I've got family living out in Utah, and my little sister was calling me and talking to me because she had a situation with one of her roommates where her roommate was having some suicidal thoughts, and she said she called 911 for her roommate. And I immediately kind of went, the police came. How did that go? You know? And she said, no, we've got crisis teams 24/7 everywhere in the state. And she's in like a little rural college town in the middle of nowhere. And I was surprised to hear that they even had that there. And just thinking about, obviously, I don't know all the details of what they're doing in Utah, and there may be gaps elsewhere in their system, but that seemed really impressive to me. And I just wonder kind of what would it take for us to get to a place like that, to have crisis teams available?
Well, and that was one of the things you asked. I guess that was the original question, right? What are other states doing better than us? I've challenged myself. What are other states doing? And truly, and Erin, Gabe, I don't know that there are other states that are doing better, but there are certainly other regions. There are certainly other areas, because we talk about the Memphis model. We talk about the San Antonio model. We talk about the Miami-Dade model. We talk about the Seattle-Tacoma model, right? There's all these other models, but I don't know personally of one where you say the Utah model. I don't know of another statewide system that is really built out statewide as a pinnacle model. Certainly there are states. I'm a little frustrated because I've been in Louisiana, I've been in Mississippi, and to know that those places are beating Iowa just absolutely pains me to the core. To think that we're 50th behind some of these other states just drives me crazy. But I know there are other models out there, Emily, and I know that there are better systems out there. We're trying to kind of track behind, like San Antonio's model with the Restoration Center and some of what they do down there, because there's a lot of cutting edge efforts that are being put out there that are really great to emulate, right? I don't know, and I leave that maybe to more of the experts in the room, but.
And I would like to toot Iowa's horn just for a moment, because while we still have lots of room to grow, the crisis services side of our mental health system in Iowa is pretty cutting edge. And we do have mobile response. I believe I have all these maps on my wall in 99 counties in Iowa at this point. There's a few new providers who have come on in some counties that didn't have that 24/7 in-person response. Where Iowa has room to grow, I think, is that continuum of services. What happens when someone enters the system through a call to us at 988 and we're not able to stabilize? Most of the time we do. Over 80% of the time, we're able to stabilize somebody on the phone and get them resources for long-term supports, but that's not always. What happens after an in-person counselor goes out and might not be able to stabilize somebody over the in person, or a law enforcement liaison is with Sheriff Thompson and they're not able to stabilize. We have parts of our system that are still lacking because individuals need different levels of treatment and long-term supports. And so I think Iowa's crisis system is pretty cutting edge. We still have room to grow. We still make mistakes. We still need to make sure that more of our 99 counties have the full scope of crisis services. But that two-person counselor approach that's happening in most counties in Iowa, we dispatch a lot of those teams. So our crisis center does that work, and there's still a lot of room to grow. But I honestly believe we need more on prevention. When someone is just starting to struggle, I think it's very confusing on where to go, if my insurance is going to pay for it. I mean, I still have insurance providers that want a prior authorization for crisis intervention. Crises aren't scheduled. So there's still a lot of work to go in Iowa. And I think that the treatment ability to access psychiatric medication management appointments and ongoing therapy, and if needed, an inpatient stay or an intensive outpatient, that's few and far between for Iowans. And I think that we've got a lot of room to grow there.
I think, Erin, you stole the answer right out of my mouth. I think the prevention piece, a lot of times I'll get a question from my wife to say, hey, I have this friend that's struggling with their mental health or struggling with a family member with their mental health. Where do they start? I think as a state, as a county, I think educating our people is probably one of the most important things, is letting them know where can they go, how can they get services, how the system works, because a lot of times that's a headache in itself. Is okay, I got in the system, but I don't know how it works. I don't know how long I'm going to wait for the continuum of care that is out there, because it's not just, yes, Erin, you are right. I think our crisis response is on the rise. It's an upgrade to what we've had in the past. But yes, at what point does the person say, okay, what's next? Okay, you guys came out, so what's next? How do I keep on moving forward? Yes, making sure that we connect them to the next level of resources is a way to prevent further harm to their mental health. So that way they have other people that can follow them and connect them. Because crisis response is just temporary. It's here, it's now. Let's help you right now. So that way you can have your next day tomorrow to see how you keep improving. So it's educating our state, educating our people, so that way they know what's available to them. So that way they can keep on getting the help that they deserve.
Yeah, absolutely. That plays right into one of these questions we got here from an audience member. It says, is there a long-term plan for those diagnosed with intellectual and developmental disabilities who are experiencing a crisis to receive support? And you really just kind of touched on that, but are there any thoughts you guys have about, any additional thoughts about how we're ensuring that people who are having these crises have a long-term help that they need after the initial crisis response?
One of the biggest things, Emily, that we're running into in Blackhawk County is short-term, we've got quite a little bit of resource. We've got adult crisis stabilization centers, we've got access centers, we've got detox centers, because we wanted that initial defer or divert to what. And so we built that infrastructure, right? But long-term is a little harder. Safe, affordable, long-term housing and placement. Those are things that we're still finding gaps and trying to address. That's a little harder nut to crack. So again, it's very easy for me as the sheriff to say, listen, safety is something I can provide. Safety is something that I am willing to, my deputies will come through. You build an apartment complex, my deputies will come through 3 times a day and high five people and check on them. My social workers will come through and make sure their meds are set up. We will assist in whatever, efforts need to happen to make sure that safety component is there. But we can't afford to pay to build the complex or convert a facility, and those sorts of things. So we do recognize some gaps, and long-term sustainable solutions like housing is a tough one. That's one that we're seeing and we're trying to tackle right now here in Blackhawk.
Yeah,
I think
definitely.
it's all about collaboration. We're a crisis services agency. We're going to stay true to that mission. As Gabe mentioned, we're that point in time intervention. We do some prevention work and we do follow-up. So I've got a team of dedicated care coordinators that call individuals at high need, that call the crisis lines that we do in-person response for, and some of our more familiar faces through our liaisons within the law enforcement departments. but we are going to stay true to what we do. We are crisis services. We're going to be here for the next individual needing something. So as a provider network, and with the support of Health and Human Services, with the realignment, we have to collaborate. We have to identify where those gaps are, if it's that longer term treatment or that prevention, how we can educate the community on the front end. I think we do a good job of that, a decent job of that in our city centers where there's a plethora of resources. I don't think we do a very good job in our rural communities. That's me speaking from Foundation 2's experience. And we're gonna work every day at being better at that, making sure that we're doing our part to educate on what our service delivery is, and then we're streamlining as best we can that next step for an individual so that they're not bogged down or confused or trying to do an application or tell their story over again, what led to their crisis point. As much as we can work together, that will help Iowans. And it's not easy.
I think one of the scariest thing is for somebody to realize that they have a mental health issue. To be diagnosed with a mental illness is very scary, especially when it's your first time having that experience. I know that because those are the stories that I've always been told by individuals that have mental health. Our job at that moment, like Erin said, we do follow-ups with the individuals that we come in contact. Our job is to encourage them, to keep on supporting them in those follow-ups, to continue their journey in regards to finding support. So that way they can get into recovery and stay in recovery a little bit longer. But it's trying to remove that fear that exists. It's just a lot of those stigmas that we all been fed into and are fed on a daily basis. It's trying to remove those when somebody realizes, holy smokes, maybe I am schizophrenic. Maybe I do have depression. Maybe my anxiety is really out of control. It's those moments of fear where when we come in contact, we try to encourage them to keep on following the path of recovery.
Yeah, definitely. We've had a lot of questions pouring in the last couple minutes, so I'm going to try and get to all of these, but we may have to pick and choose a little bit. This question looks interesting to me. It says, do you collect data on the cause or trigger of crises that happen? Can we look back and see how many issues were a direct cause of specific incidents like interpersonal conflict, missing medications, losing a job, or other situations? Or are many of the crises more complex than this?
I think it's a mixture. It's a mixture of all, but yes, we keep all that data. We try to, as a state and even as regions and stuff like that, we're all trying to figure out what is happening, what's going on. And yes, we collect the data. Was it interpersonal? Was it because somebody just stopped taking their medication? Was it because of an assault, or am I using a substance abuse because I'm grieving at the moment? So yes, we do keep track of the causes or what the root cause are of phone calls that we receive.
And the question hit on a lot of the major factors, right? Decompensating, soliciting street drugs in lieu of their pharmaceutical medication. They hit on several of the major categories that we respond to. So, but yeah, we track.
I'll echo that. We track anything that comes in on the crisis lines to our in-person response and some of our other services. And it is very complex. Often there are multiple presenting issues. And as I mentioned before, crises are very individualized. So somebody with persistent mental illness, that might be different than an individual who might be going through an unexpected relationship breakup or something of that nature where they've leaned on substances or something else to cope. And that coping mechanism, one, probably wasn't very healthy, and two, has stopped working. So we do our best, and we work with all of our partners, including the state, to provide that information to get a better sense of, is there something systemically that's happening? Also, we track after the pandemic was its own reason, and we layered in that sort of data collection during the heart of COVID-19, as well as we've had some natural disasters here in the Cedar Rapids area that we also try to relate if a crisis is related to a natural disaster or something unexpected a community might experience.
Right.
And the
Yeah.
good thing about data is not just tracking the calls that we get, but we also track ourselves, because I will say a data that we do collect is how quickly do we respond to these situations as well, because that is a key component to somebody staying as healthy as possible.
Absolutely. We've got a question here about working with insurance companies. I know this was something Erin kind of briefly mentioned earlier. The way this is phrased, they said, how ready are we to build the most effective services rather than just build services insurance companies want to cover? Is there, where do you have to draw that line, I guess, between working with what people need and then working with those insurance companies as far as making sure they have access for paid for services?
Well, I'll start. The crisis services system is really not supported through insurance payment. So I did mention a prior authorization for a crisis. The state has to be the communities, they have to fund the crisis services system. No offense to Sheriff Thompson, they are our first responders and our law enforcement officers keeping us safe. But my team on 988 Your Life Iowa and Gabe's team, all of us that are going in person, they're first responders and saving lives as well. So our services have to be funded in that way. It's not a fee for service. I'm going to schedule Tony's crisis tomorrow at 7 p.m. and I'll knock on his door. It just won't work. So we operate in a firehouse model. I have team members on 24/7, 365. They have to be on, they have to be ready, just like that 911 dispatcher or that law enforcement officer, that EMS provider. So the state has to step up, the individual communities, the counties, whatever that mix looks like, to fund the crisis services side. There is some reimbursement for minimal crisis services services. It is not how we ensure that we're able to operate programs. So it just wouldn't work in that way. So I think we do have a funding structure. I don't feel like crisis services are fully funded. Again, I believe they are life-saving positions. So we're still working on making sure that funding stream is steady, sustainable, and the rate that should be paid for the work that's being done.
And not just crisis response, but also 988, because we're not just diverting from the criminal justice system, we're diverting from death, right? I mean, these are things that if someone's calling 988, they're calling for a reason, right? So we need that funding across the spectrum, and it's got to be a wholehearted, full 100% in for a penny, in for a pound investment. I laugh when you talk about pre-authorization for the next crisis. That's humorous, but it's a problem that I don't have to worry about. But clearly, this is where the rubber meets the road when it comes to mental health investment.
Yeah, definitely.
I think this is where you typically get that answer where you say people need to contact their representatives and their legislator and stuff like that, and give them a piece of their mind when it says, hey, we probably should be doing this, so that way we can provide a better services. Yes, Medicaid does provide some reimbursement for crisis services. Can the rates be better? Yes, the rates can always be better to provide us a full encompassing services for the people that we assist. Another push that I would say is trying to figure out how to help private insurance also do the same, because it's one thing for the state insurance to provide crisis response, but if there was a way to educate private insurance and let them know, like, hey, you probably should provide this coverage as a necessity for the individuals that you serve, because that's also part of it. We're not just serving individuals that have Medicaid, we're serving the whole state. So those that's Medicaid, uninsured, and people with private insurance. So it shouldn't just fall on the state, but like Erin said, a lot of it does fall within the county's regions to provide the service.
And we know that proactivity is cheaper in the long run than being reactive, being responsive to whatever the next crisis is, right? Because in the long term, it's going to cost the counties, it's going to cost the hospitals, it's going to cost insurance, it's going to cost everybody more. We know we're talking about high frequency users of whatever system they're engaged in. And so being proactive, being on top and in front of of treatment is always cheaper. So it only makes sense to be proactive with funding.
Yeah, absolutely. All right, we've got a question about the staff that you guys work with to do these liaisons. Someone says, how have you seen liaisons in larger cities perform for those in crisis, and how do you support them through supervision and management? Does our state need to better support these teams in order to have greater outcomes?
Oh, man, Erin, sorry.
No, go
I-
ahead, Gabe.
I think I have an amazing team here in the Polk County area when it comes to our crisis response services that we have. I know we have a continuum of services here in this area. Yes, we do have to take care of our staff. We do have to make sure that they have the appropriate training to be able to handle the situations that they're going to come in contact with. And we do that with trauma-informed care. We do that with safety, first aid. We teach them how to de-escalate situations. We do CIT training as well. So that way we give them the resources that they need to be able to provide the services that they can provide at their best level. But yes, this job is taxing. It can be taxing because we are living the person's trauma at that moment with them, whether we think we are or not. So it's our job to make sure that we find ways to us and get away from it as well. So that way we're taking care of ourselves, so that way we can give the person the best that we can when they need it.
Our entire team, anyone who works at Foundation 2, is angels walking among us. They have hearts of gold. Secondary trauma is a very real thing. As Gabe said, they take the work home with them. At an agency level, we focus a lot on our employees' work-life harmony and their own mental wellness. We do small things, but 2 mental health days, no questions asked. If you need it, you take it. We have a restoration room and calming spaces in our offices. We do debriefing sessions after difficult calls. I would say for our liaisons, specifically embedded, we say embedded, not employed. It's important for that person to be a separate entity from law enforcement. There are certain individuals that have a visceral reaction in many ways to law enforcement. And they also get that training that Gabe mentioned. We always say when you come to work here, you don't get to coast in your first 4 weeks, you're coming to school. You get a lot of training, a lot of role playing and shadowing experiences, because we want the individuals to be set up for success. And at the end of the day, when that team is responding a little differently than mobile crisis or some of our voluntary services, they're coming off of a 911 call. So the individual might not always be expecting them. So they just say, hey, I'm Erin. I'm here to help. How can I help you? And they're listening and compassionate. They're good at de-escalation. And they queue with their law enforcement partner really, really well. And we do our best to take care of them, and we can do a better job as well.
We take a little different tack up here. We do have an embedded resource with Elevate up in Waterloo, with the Waterloo Police Department, but I also have a social worker that's also a deputy sheriff. And her partner happens to be a canine, a de-escalation canine, a crisis response canine, big scary dog named Mary.
What kind of dog is Mary?
Mary is a black lab, and she loves pets and rubs and I'll tell you, she's from New York. She was trained in the New York State prison system by inmates. And then Carla, our canine handler, Mary's mom, how she's referred to, went out and was trained by the inmates on how to work with Mary so that Mary can do her job. And Mary is so intuitive. I watched her work one day at an assault trial where a 9-year-old had to testify against a father in a sexual assault, and to watch this dog detect the stress, the escalation of human emotion and de-escalate that was absolutely amazing. I could have paid $1 million for that dog and I would have been impressed with the outcomes. And then to watch the young lady come out of the courtroom and Mary jump up on her back legs and give that girl a hug and lick her face and lick the tears off of her face. I was blown away. But to know that that dog goes out in the field, and even though it's a uniformed officer with a social work background that goes in, and again, we are the enforcement arm of the court, right? As sheriffs, we do involuntary committals, emergency committals, and we take people out of their homes that need assistance. We take them to the hospital. We're their taxi rides, right? And so oftentimes that's a difficult task to do. You would be amazed at how many times already Mary has helped de-escalate, calm things down, and I will only go if I can ride with Mary. Okay, fine, no problem. And they pet Mary all the way to the hospital. So it's a little different approach, but it's an approach that's been effective. I probably will not buy another drug dog. I will probably continue to encourage this de-escalation, crisis response, canine approach, because the proof is in the pudding for me.
That's precious. I love dogs.
Well, I
We've
love
been
Mary,
debating a
even though
crisis
she's a bit of a
canine.
trash panda. She comes in and we have to keep her out of the trash, but
We've been
yeah.
debating a crisis canine, so I'm going to touch base with you offline regarding.
Huge, it was a huge F, and she's a facility dog, so she recognizes when I'm having a bad day too. Puts her head on my lap. So
That's awesome.
yeah.
All right, we've got a question here from someone who is a mental health provider. It says, for those of us who are mental health providers, do you have things that we can do to help mitigate prior to a crisis taking place?
I think.
Go ahead, Erin. Go ahead, Erin.
I was going to say, I think that mental health providers, medical providers, schools are doing better than they ever have. We believe in suicide training and that we are all suicide prevention experts. And so any trainings that that entities, agencies are open to, so that their staff are comfortable kind of identifying some warning signs of potentially a behavioral health or mental health crisis, and the comfort with that early intervention, even if it's let me call 988 together with you so you know what this experience might be. Also, I think the screenings, more universal screenings, both for suicide, whether that's the Columbia brief screening or for depression, that can happen. The more we're able to help someone identify and help them through that initial fear. Like, it's okay not to be okay. I don't know anyone who wouldn't seek the medical treatment if they fell down and injured their arm. But so that's what I would say is keep doing what you're doing, keep talking about not being okay. If something's a little off, screenings are very, very helpful, and continued training for the front desk staff who's checking someone in, if for them to recognize signs of symptoms, or to say, hey, are you doing okay with everything that's going on in your life that you've told me? Are you having thoughts of suicide? And then knowing what their next intervention might be. And that might be, hey, call 988. Or let's call mobile crisis, and I'm going to sit here with you until they get here.
I think as a mental health provider, you know the individual better than you're going to know the individual better than the crisis responder. So I think in that regards, yes, do everything that you can to try to mitigate the situation, but don't be afraid to call us for assistance. Do not be afraid to call for help in those instances. And like Erin said, offer that support of, hey, I'm gonna get you somebody that can help us. And an analogy that I use, it's almost like my kids. Sometimes I feel like my kids don't listen to me, but then I hear reports from their friends' parents, and I have perfect little angels, and I'm like, well, excuse me, what? So you know them better. Yes, you got the experience with them, but sometimes all it takes is an outside face or somebody with a different approach that they're not used to help them get that healing that they need for that moment.
I'm going to talk about two very simple things: collaboration and partnership. So as a mental health provider, the more partnerships you build, the more handshakes you have, the more collaboration you've got with all these other agencies, all these other organizations. How many times have you sat down with your local sheriff, with your local responders, with the ambulance crews, building that familiarity, building that camaraderie, building that partnership, that collegiality with those organizations that you're going to be interfacing with before the crisis occurs, so that when you call, they know who they're talking to. They know that they can rely on your expertise. They know that they can take stock in your experience, in your knowledge, in your exposure to this client, to this patient. All of that builds credibility. It builds again, that partnership, that cohesiveness, and it helps bridge some of those gaps too. That's issue number one, or at least perspective number one. Number two, I'm just going to throw out 3 trainings that I think are probably the most critical that we subject all of our staff to. Crisis intervention training, the 40-hour full curriculum, mental health first aid, and trauma-informed training from SAMHSA. All of those 3, I think, are huge tools to put in a toolbox for anybody that does this kind of work, and major investments that are well worth the payout on the backside.
I'm going to add one more training to that. There are evidence-based community for individuals, any teenager and up, for suicide prevention training. It's really a comfort level about talking about suicide and then knowing what is next, not being the interventionist, not providing that intervention, but being comfortable to talk about it. I'm going to add that 4th training.
Absolutely. All right, we're getting close to the end here, so I'm going to just do one last kind of overarching question, and we'll get a quick response from each of you, I think. But let's just go very general, but talk about, from everything we've talked about today, what would be your main takeaway for our audience members that you want people to remember and take with them, actions they can take, or kind of what they should be focusing on going forward in this field?
Can I go first this time?
Sure.
Because I'll be the dumb knuckle dragging cop that won't have a whole lot to contribute, and then these 2 scholars will lay it out there for you. My 2 big things, we talked about it very briefly, but I want to re-emphasize and just put a spotlight on it. Destigmatization of mental illness. I think it's huge. I think if there's one thing that we can do that doesn't cost much, is really, what do we have? 50 some people. 43 now involved in the chat. Every single one of us can spend just a little bit of time recognizing that when we see that out there in the community, that we can react and respond to it, recognizing that we all have that implicit bias about us that, oh, that's mental illness. I know that, destigmatize it. Even just acknowledging, hey, how's your day? I see you. I recognize that you're a part of our society. I recognize that you exist. You would be surprised how many people come in after having spent time in the jail just to visit, just to socialize, just to build their network and validate their self-worth with somebody recognizing that they're here. And I think that's important. Destigmatization is a huge, huge piece. Number 2, it's that investment in the system, letting our lawmakers know that we as taxpayers value their investment in our mental health system, the importance of their investment, their spotlight, their focus on mental illness, and the importance of us getting out of that 50th, 51st ranking. We shouldn't be 50th in anything in the state of Iowa, but certainly not in taking care. We are our brother's keepers, and we have not done a very good job at that lately.
All right, you've both got 30 seconds.
I'll keep it simple. If you don't know where to start and you're experiencing any sort of crisis, call 988. There's a compassionate counselor trained, ready to help you 24/7, 365.
I will keep it simple as well. We are out here. Mobile crisis response services are available to you in the community. You're going to be seeing a lot of behavioral health urgent care clinics popping up here. We have a few here in Des Moines. Don't be afraid to reach out for help. Even if
For
that
you
means,
or a
even if
loved
that
one.
means calling 911, exactly, for yourself and or for a live. Even if you start at 911, most 911s will get you connected to a mental health specialist if you need it.
I suppose that destigmatization starts with us, right? Starts with
Yes.
yourself. Yeah.
Absolutely. Well, thank you guys so much. We really appreciate you being here. I think this has been a really productive conversation. And I'm glad to have been able to moderate this. So thank you to our audience members for tuning in. Be sure to tune in the next couple of days, Thursday and Friday. We've got 2 more mental health focused discussion sessions. And just thanks again to our sponsors, to Foundation 2 and to ITC Midwest for helping us to have the ability to put these conversations together.
Thank you, Emily. It was an honor.
Thank you, Emily.
Thanks, guys.